And I'm ready to go.
Sure. Yes.
Yep, perfect. Good morning, everyone. Good morning. Welcome to the National Hispanic Council on Aging's Capitol Hill briefing. I am so excited to moderate today's event. My name is Jeff Cruz, and I am the Executive Director of the Latinos for Secure Retirement Coalition. And as I said, I'm so excited to be here for this discussion on important issues and how they impact the U.S.'s Latino community, and most importantly, what we could do to solve and get solutions to these problems plaguing our community. We have a great panel here today. These legislative briefings are designed to educate lawmakers on these issues and, again, facilitate discussions. We're not just talking about problems, we're making recommendations to members and their staff and looking to get policies that will help our community. Today, we have experts on topics such as the 340B drug pricing program and on counterfeit anti-obesity medications. I also want to highlight that if you go on NHCOA's social media, their website, they have a Facebook page, they have Instagram and X, and you can find them at their handle at NHCOA. And very, very soon they will be releasing the annual status of Hispanic older adults report, SHOAR, SHOAR, which is a data and testimonial driven report with more policy recommendations on the challenges facing Hispanics, older adults, their families, and caregivers. So please check out National Hispanic Council on Aging social media. They will also be doing a Capitol Hill briefing in person on December 10th. So you can find out more information on that report and briefing online. I also, there's a lot of work that goes into this. So I want to thank all of National Hispanic Council on Aging staff for putting this on. I also want to thank the sponsors and partners because without them, we wouldn't be able to do this discussion. So thank you, Nova Nordisk, AstraZeneca, Bristol Myers Squibb, Eli Lilly, and Verizon. Thank you for bringing us together so our community could unite and solve issues plaguing us. And so to begin this event, it is my absolute pleasure to introduce Dr. Yanira Cruz, who is the president and CEO of the National Hispanic Council on Aging and one of the nation's leading advocates and spokespeople for diverse older adults. She's really smart, but she's also really nice. And just a great person full of insights and thoughts on how to help our community. So I'm really glad to introduce Dr. Yanira Cruz. Please take it away.
Thank you. Thank you, Jeff. Thank you for your kind words and your introduction. Good morning, everyone. I'm delighted to be here again with all of you. Want to say thank you to our panel of experts who are joining us today, this morning. Thank you for sharing your knowledge and your wisdom. Every time I think of these briefings, whether they're virtual or in person, I always remember the stories that I come across with from individuals who participate. And of course, today the event is virtual, but I remember the last time we had an in-person event on Capitol Hill, and I was approached by one of our members. Her name is Isabel, and Isabel was very concerned that Medicaid policy was changing and that she would be impacted by those changes. She is a cancer survivor twice, and so her health is important to her, but it's also very delicate, and she needs to keep good track of her nutrition, etc. So she was very concerned. She approached me after we spoke during that briefing, and she reminded me of the reason why we do these things. It's about people. It's about human beings. It's about Isabel and the so many Isabels around the country who are worried because policies are not meeting the needs fully that they have in terms of keeping up with their health and aging with dignity. So I would like to just, follow with by saying that that I, just want to acknowledge and recognize that Hispanic Americans are an essential part of our nation's past, our present, and our future. We have a population exceeding 68 million, about 20% of the total US population, and Latinos represent the country's largest ethnic minority and one of its most dynamic sources of cultural, economic, and civic vitality. So we're talking about, a population that is significant, and that, we're just delighted that we're able to create this space to be able to talk about Latino health. And so this morning, I will be brief. I'd like to just also emphasize that every year, the National Hispanic Council on Aging collects data, whether it is through stories that we collect, through surveys, through secondary analysis, to get us to a report that shows the nation how we're doing, how are Latino seniors doing in our country. And so this year, we put together that report once again. It's heavy emphasizing health, because health is a big concern these days for our seniors, particularly access to health care. So I will, limit my comments primarily to some of the recommendations that we're highlighting on this report this year. And of course, as Jeff has indicated, the report will be available online for you to read, and I believe it will be available in English and in Spanish. So first, one of the key recommendations that we are putting in the report, including in the report, is to expand access to cholesterol screening and management programs. Cardiovascular disease remains one of the leading causes of death, impacting about almost half of Hispanic women and Hispanic men. The primary way to prevent serious complications related to cardiovascular disease is to go through a cholesterol screening as early as possible. So policymakers should ensure that all older adults, particularly those from underserved communities, have access to regular cholesterol screening, personalized counseling, and effective treatment options. And so the second recommendation, which you will hear more about from Mr. Johnson, is to strengthen the 340B program to ensure patient benefit. The 340B drug pricing program was designed to make prescriptions drugs more affordable for low-income disadvantaged patients. However, it's been used to create profit for bad-acting healthcare providers at the expense of their patients' wallets. And so Mr. Johnson will lead us in a conversation to give us more detail about this in a little bit. The next important recommendation that we're making is to expand osteoporosis screening, education, and treatment. With its silent approach, an older adult is unlikely to know that they have osteoporosis until they have suffered a bone fracture, which may occur with a slight movement as a sneeze. And so the best way to prevent these accidents is by catching it as early as possible with bone density tests. So we're urging to screen as early as possible on that. We conducted an assessment specifically on osteoporosis, and Latinos, for some reason, Latinos do not consider themselves a risk for osteoporosis. They think osteoporosis is a disease that impacts only other populations and not them and not Latinos. So I think it's critical that we have federal and state leaders, making sure that we have increased access to osteoporosis screening, particularly for women, particularly women of older age. Medicare should cover preventive bone density screenings, and the Department of Health and Human Services should support culturally tailored osteoporosis education through trusted community-based organizations and promotores de salud, or lay health educators. Next, we're also highlighting advancing obesity prevention and treatment equity. As you know, we have been addressing the issue of obesity for some time as an institution. And from 2017 to 2020, the prevalence of obesity in the United States has been around 40%. And specific to the US Latino population, that percentage is a little higher. It's about 45%. So for this reason, we believe policymakers should also address the growing threat of counterfeit medications by strengthening FDA oversight, by promoting public education on misinformation, and expanding insurance coverage for safe and effective medications. And Dr. Serrano in a little bit will be highlighting the importance of this topic. Next, we also are recommending that we prioritize mental health equity and schizophrenia awareness. The importance of proper understanding of mental health and serious conditions such as schizophrenia cannot be underestimated. And Hispanic communities face a unique barriers to mental health care, including things like stigma, cultural misconceptions, and limited access to bilingual providers. And so we're urging Congress to expand funding for community mental health programs, to integrate culturally competent care models, and support parity enforcement so mental health services receive coverage equal to physical health care. So I will just end with, increasing adult vaccination coverage in Hispanic communities. Federal and state policymakers should ensure that adult vaccines, especially things like COVID-19, RSV, influenza, pneumococcal vaccine, remain free and accessible to uninsured and underinsured adults. Culturally tailored vaccine outreach is also important, to be led by trusted community partners such as community health workers, and they should continue to receive funding to promote vaccination rates among Latino populations. So with that, those are some of the key recommendations that we're making in this year's Status of Hispanic Older Adults report. There are other recommendations that I have not included here, but I invite you to visit and to read the report. I think it gives us a sense as to how we're doing in terms of Latino seniors in our nation. So thank you again for being here and for making your voices heard. And I turn it over to our esteemed moderator, who will lead us through the rest of the webinar. Enjoy.
Thank you, Dr. Cruz. I know you don't get the applause when it's live stream, so I'm going to applaud on behalf of everyone, and you can just imagine all their faces. Great speech. I think, Dr. Cruz outlined some of the challenges we're facing and then a lot of solutions as well. I worked on Capitol Hill for 15 plus years. We won a lot of victories with, enacting legislation to help people, but there's not a single victory I've ever done by myself. Politics is a team sport, and you win when you're engaged and you're organized. So I encourage everyone listening to be involved with the group. You could become individual membership. The program the National Hispanic Council on Aging has, where you could sign up for $25 a year and you get access to exclusive resources, educational workshops, advocacy tools, and bilingual information. So I encourage you guys to join them, join LULAC. I'm with Latinos for Secure Retirement. We are doing our relaunch event on November 19th at 9 a.m. I will put information about that live stream. Dr. Cruz is going to be speaking there as well. We're delighted to have her. And you can learn more about our coalition and the work we're doing with National Hispanic Council on Aging. That's going to be November 19th. I'll put the sign up in the chat. Keep in mind, it may say a different date because scheduling during the shutdown when the speaker cancels the House every Friday for the following week has been a little bit of a challenge, but it'll be November 19th. You can still sign up and that will be updated momentarily if it says a different date. I'm going to begin the panel in a second here. Remember, if you have questions, just put it in the chat at any point. We will hear both our panelists and then I will read questions at the end. So we welcome questions, thoughts, suggestions. Put it in the chat and we'll get to it at the end. And so now it is my great honor to introduce our first speaker, Thomas Johnson, who is the Executive Director of ASAP 340B program. And so we are delighted to have Thomas Johnson there. This program is very important because so much of our community depends on drugs that literally save their lives. And so we need to make sure people get the medications they need. And with that, let me hand it off to Thomas Johnson. He's going to go into a lot more detail than me. And again, if you have questions, please put it in the chat. Mr. Johnson, please.
Thank you, Jeff. Appreciate it, and good morning to everyone. I have been executive director of this coalition for a little over 2.5 years. And what I want to do is talk about the coalition, talk about the program in and of itself, and the work that we are undertaking to try and bring about some needed reforms to the program. Next slide. So these are partners of our coalition. We formally started in April of 2023. We actually added 2 new partners over the weekend. So we are now up to 41 coalition partners, and they represent different types of national organizations. The 2 main partners that we have are Pharma and the National Association of Community Health Centers. We're happy to say that the National Hispanic Council on Aging is also a partner with our coalition as well. But you can see the breadth of coalition members that we have. Next slide. So we've come together because of this program, the 340B program, was created over 30 years ago. And this program helps low-income and other vulnerable patients access more affordable medicines. Community health centers in particular and other safety net providers rely on this program to serve their communities. But because some entities participating in the program have taken advantage of its lack of clarity at the expense of patients that it's meant to serve, there are some practices that are taking place that we think go against the nature of the program, go against making sure that patients have full access to the program, and in fact are harming the safety net that the program was designed to help. The well-being of communities served by this country's healthcare safety net is at stake if these reforms aren't implemented. Next slide. So I'm just going to talk a little bit about what the 340B program is and how it should work. And unfortunately, some of the things that are happening now with regards to the program. So I stated this program was created a little over 30 years ago. And essentially what's supposed to happen is a manufacturer, if they want to participate in a public program such as Medicaid or Medicare, they have to enter into an agreement with covered entities that are outlined in the statute such as hospitals, clinics, and other types of groups. They have to enter into an agreement with that entity, and that agreement will have the manufacturer provide drugs at a discount of its normal price to that covered entity. So right now, the discount is averaging about 59% of the normal price of the drug. The covered entity is then allowed to keep the remainder of what would have been the full price of the drug when they bill a payer such as Medicaid, Medicare, or private insurance. So essentially, they're able to keep almost half of what they originally purchased the drug for when they bill Medicare, Medicaid, or private insurance. So this is a way for covered entities to stretch their resources in a way that they can acquire drugs at a discount and also serve the patients that they serve. That's how the program is supposed to work. Unfortunately, what's happening now is that with certain entities, specifically hospitals, once that discount is applied, what they are doing is that they are actually charging, instead of that full price of the drug, there are a number of hospitals that are actually charging 5 to 10 times the price of the drug that they acquired the discount for. And the PBMs are now getting involved. They are helping the spread of that price and setting up an arbitrage system to help that entity collect much more and keep much more when they bill Medicaid, Medicare, and private insurance. In some cases, they also are extending to the patient a copay in addition to billing Medicare, Medicaid, or private insurance. And there's a specific example that we pointed out that was reported on of a woman who was being treated for metastatic cancer. The drug price that the drug was acquired for was $2,700. They billed Medicaid $27,000 for the discounted drug that they acquired. They were paid by Medicaid $10,000. And in addition to all of that, they still sent out a bill to the patient for $2,500. So essentially, they were seeking to recover 10 times the price of the drug, and they actually recovered 5 times the price of the drug. And this is the type of practice that we think covered entities, and specifically hospitals, should get away from. And it goes against the nature of the program, which is to serve the underserved. Next slide. So I talked about that example, and that's just one way 340B is not working as intended. The program has extended significantly, as has a number of covered entities and middlemen. Hospitals are now the largest beneficiary, as you can see from the slide. They represent 87% of the purchases that are made under the program. The next highest category of purchases made under the program are community health centers, which is at 5%. The total amount purchased under the program, discounted purchases, total $66.3 billion, making this the second largest prescription drug discount program in the country. There are a few transparency and accountability measures that go along with the 340B program. If you are a federal grantee, you have certain requirements with regards to reporting than if you are not a federal grantee. And hospitals are not federal grantees, but clinics are. And I'm going to go through the differences between the two in terms of transparency and accountability. But when you don't have that requirement, being a federal grantee, essentially you can use the savings for pretty much whatever you want. So I'm pointing out in a number of reports, including reports by the federal government, that 340B benefits flowing away from low-income communities as hospitals are prioritizing patients with higher paying private insurance. This really helps hospital consolidation, which does not work in the interest of many of the providers and entities that are in the program, but it also does not work in the best interest of patients. And PBMs and other middlemen are siphoning billions from the program to the tune of, in 2023, $2.5 billion. Next slide. So I talked about this issue of accountability, and I want to go through the differences between what community health centers encounter as a federal grantee and what 340B hospitals have under this program. The community health center qualifies for 340B status as a federal grantee. They are required to report how grant funds and 340B savings are used. They reinvest those savings back into patient care, and they also apply an income-based sliding fee scale for patient drug copays. Now contrast that with what you have for 340B hospitals. 340B hospitals qualify for the program by serving as a disproportionate share hospital, having a disproportionate share of low-income patients. However, in the actual 340B statute, there is no federal requirement to report how 340B savings are used. So what we have heard are stories about 340B dollars being spent on things that are not healthcare or patient care related, such as Super Bowl ads, such as paying for the salaries of a football coach, such as capital improvement projects. Those things not being related to patient care. There's also no obligation to reinvest those savings into patient care. And with all of this, those hospitals, while they are required to provide charity care, 2/3 of DSH hospitals were below the national average of 2.5% of operating costs. Next slide. Now, this is specific to the point I just made about 340B hospitals providing less charity care, and I understand that they receive a tax advantage as a 340B hospital. On average, they are providing 2.15% in charity care. Nonprofit hospitals provide 2.3%, and for-profit hospitals provide 3.8%. Next slide. 340B hospitals are not, 340B is not working for cancer patients, especially in the hospital space. I talked to you about the situation with the one patient already that had metastatic cancer. There are a number of groups pointed out that even though 340B hospitals buy drugs at steeply discounted prices, many cancer patients find themselves paying more. And this is, again, for a discount program. 340B hospitals tend to use higher cost cancer drugs, netting larger profit margins. Revenue earned by those hospitals for cancer therapies was over 10 times higher than at non-340B hospitals. So there is an incentive to use higher cost cancer drugs the way this program is set out. And 5 of the 10 drugs, top 10 drugs that are used in this program are indeed cancer drugs. Also, the state of North Carolina issued a report, and the report found that 340B hospitals charge state employees more than 5 times their cost for cancer drugs, which is an 84.8% markup. And you see at the bottom of the one example that I talked about earlier, a patient being billed for $22,700, a drug that costs a hospital $2,700. Next slide. So there has been activity in Washington over the past year. Legislation's been introduced, or there have been drafts of legislation that have been worked on by a group of senators called the Gang of Six, 3 Democrat and 3 Republican senators. And those senators are outlined in the slide. I'm happy to report that last week, the Senate Health Committee actually had a hearing, an oversight hearing on the program in and of itself. And the good thing is that we found that there were Republicans and Democrats that actually saw the importance of adding transparency requirements and reporting requirements to the program and address some of the other issues that we've raised as a coalition. So our hope is that that committee, which has jurisdiction over the program, follows up with legislation for the committee to consider. There are 3 members of the Gang of Six that are actually on the Help Committee. And the chair of the Help Committee, Senator Bill Cassidy, issued a report in April that was critical of some of the practices taking place under the program. And he has called for action. And so we hope that he'll be able to follow up on that during this congressional period. Next slide. In addition to our coalition, there was a December 2024 letter to Congress from 13 health equity groups that they sent to the Gang of Six, calling for legislative action. Most of the groups that are listed here are actually members of our coalition as we speak. And so there are many others, even outside of our coalition, that are calling on Congress to reform the 340B program. Next slide. So our solutions in a nutshell, we want to make sure that 340B works for patients, because patients are ultimately the people that we all serve. 1, we want to make sure that savings are used to help patients and true safety net providers. 2, we want to make sure that middlemen are unable to abuse the program. And 3, we want to be able to verify that the program is actually working. And that comes with transparency and reporting that we think is indeed called for the 2nd largest prescription drug discount program in the country. Next slide. If you want to find out more about our coalition, you can visit our website at www.asap340b.org to learn more. And Jeff, I thank you.
All right. Thank you, Mr. Johnson. I know that was a great presentation. I know I have a lot of questions I want to ask you. We're going to hold questions until both panelists go. Audience, remember, if you have a question that you want us to ask Mr. Johnson, please put in the chat. I think there's a question option. But we're going to hear from our next speaker first, and that's Dr. Ray Serrano with LULAC. I think I mentioned I'm with Latinos for Secure Retirement Coalition, and I just want to talk a little bit about LULAC. They are the nation's largest civil rights organization and one of the nation's oldest. Social Security is so critical to the Latino community. The majority of Latinos rely on Social Security for the bulk of their income. When President Bush in 2005 tried to privatize Social Security, LULAC started the Latinos for Secure Retirement Coalition, and we were able to successfully defend privatization. It went dormant. Then Simpson and Bowles Deficit Commission came, and there was a lot of attacks on Social Security again. We reformed it with LULAC support in 2010, and they were critical. Like I said, they're the nation's largest Latino organization with really strong roots in the community. So really delighted to have LULAC here. Please, check out their social media sites and join them. Dr. Ray Serrano is going to talk a little bit about obesity and counterfeit drugs. As obesity rates rise in America, so does the demand for weight loss drugs and supplementals that'll help you stay fit. Unfortunately, this demand has really opened the gates for a flood of counterfeit and unregulated products, many of which, are ineffective, mislabeled, but some of them are even, outright dangerous and harmful. So we're really delighted to have Dr. Ray Serrano, the Director of Research and Policy at LULAC, League of United Latin American Citizens, here to join us. And Dr. Serrano, please take it away. You're muted. Yeah, there you go.
There you go. Thank you so much, Jeff. Yeah, no, I very much appreciate the introduction. I think, I think there is a lot right now happening in the health space, particularly for access and for Latino seniors, and I think for just Latinos in general. When it comes to chronic disease, that seems to be an area for Latinos. I would say that the biggest ingredient in chronic disease is our own powerlessness. So I think quite often we see, whether it's obesity, diabetes, asthma, you name it, it's our inability to try to ensure access for us, and our inability to try to prevent or to kind of address the built environment or the contextual factors that are causing us to be sick or getting sicker. And on the issue of obesity, it's not anything new. I think this is something I often say the phrase diabesity because I think quite often they're very one and the same. So you have obesity that leads to diabetes, or diabetes that leads to obesity. But for the purposes of this presentation, I'll just talk about obesity as a kind of just a classical, high BMI. So we know that there is obviously a problem for minorities, for Black, Latino, and Native American, and really overall of all Americans, but disproportionately higher for Latinos and African Americans than any other group when it comes to obesity. There's a crisis in that sense that folks are just it's not even overweight. If we look at overweight, they're at 85%, but if you look at just obesity, it's about half the adult population. Getting access to treatment for it has always been kind of a tongue-in-cheek idea. You got to, stop eating these things and start doing this. But in many ways, we also know that it's a disease. Since 2013, the American Medical Association has categorized obesity as a disease. Yeah, it's one of those diseases that doesn't seem to get the attention of other diseases. It seems to be always I always equate it to HIV in the sense that people always go back to how you got it, and they can't get over that fact and that blame and the stigma that comes with that, and they never quite get to the idea of how to be treated. And they never want to, like when we had antiretroviral drugs as a solution for HIV, that was never there's always this idea of, well, why should we have to pay for that? They chose to get it. It's the same thing with obesity. Why should we have to pay for GLP-1s? They chose to get it, as if it was a choice. So in this presentation, I just want to give you the whole landscape of what we're seeing in this darker period of what has happened. So next slide. So as I mentioned, obesity is a big problem, and it is a problem that we see consistently among adults. And so for African American women, they're the highest group that most affected. It's over 50%, followed by Latino women, followed by African American men, then Latino men. So it depends on what data set you're looking at. This is from 2017 to 2018. If you look at more recent ones, it's about basically half the adult population of Latinos and African Americans are obese, not overweight, obese. If you look at overweight and obesity, you're at 85%. And so if you look at Latino kids, it's the inverse. So if it was more women that are being affected as adults, then you're looking at young boys being affected for Latino boys. In that case, it's about 1/3. And again, and growing. So what we're seeing is that over 50% and soon to be 55% of our adult population will soon be obese. And so what I say sometimes is that obesity is kind of that key that unlocks the door for about 206 chronic diseases that we know of. That comes, and so think about it, the sleep apnea, congestive heart failure, hypertension, diabetes, you name it, all of it. So I say in many ways it unlocks the door to become, so if somebody who's a kind of a if obesity was going to cost you so much to treat at this point, it also, if you don't treat it, there's a cost for inaction. And should you do that, you basically unleash what I call the $1 million patient. And so it basically takes about $1 million to restore that patient back to some sense of normalcy. So if I can go to the next slide. Sadly, it's not getting any better. And I wish I had better news that we were on the up and up on things. But when it comes to food deserts, we're seeing that the number of people who live in low-income areas, the access to a supermarket or a grocery store is getting less and less. And folks who don't have access to transportation, folks who can't get a driver's license, you'll see that more and more. What is interesting for Latino and Black communities is that if you have the food desert, you also have the fast food swamp. And the fast food swamp seems to be very manifest. And you know, most, like if you drive into an area that's predominantly Black or Latino, you'll see the Burger Kings, the Wendy's, the McDonald's, and you know, with the dollar menus, and they're all congested in one little corner. And when you look at the percentage, and this actually shocked me, the percentage of how many folks eat this on a daily basis, fast food, is really high. African Americans the highest, followed by Latinos. 1/3 of Latinos eat fast food daily. So again, think about the guy who's working at construction. He goes to McDonald's to get his meal, and then he comes back to work. I mean, it's quick food, it's fast, it fills the belly, but it's not healthy, and the amount of calories that it consumes. So they say, well, okay, well, why can't folks just eat healthier, right? There's also a big part of it's food security. And the idea of folks don't have access to the money for it. And the one thing I hate when people talk about, well, there's so many people on food stamps that are living so greatly. I'm like, really? Are they really? Let's just break that down. Let's see what DC looks like. Let's look at what Maryland looks like. So I wanted to just show you what it costs, what the SNAP benefits for food stamps is per person per month. So it's $187 here in DC, $187 in Maryland, and $178 per month. That equates to about $6 a day, for all the DMV area, which equates to, if you have 3 meals per day, less than $2 a meal. So anybody who pushes back the thing that food stamps and somehow we're living luxury, we're eating filet mignon and all these great things, I encourage them to go on this SNAP benefits diet, to just go, and for $6 a day, that's all you can eat, and eat a meal for breakfast that's less than $2. And you'll find how difficult it is and how hard it is to even reach those hard to reach, food, like to buy certain foods. The other thing I wanted to mention, I just posted this from Politico, this is just yesterday, sadly, is that we're seeing food being used as a weapon. They will shut down, as of Saturday, food aid through SNAP benefits if the government stays shut down. So basically, that's the idea of for Democrats and Republicans not to come together on a common plan by Saturday, we're basically going to starve the poorest of the poorest, which is absolutely just cruel and wrong. So I can talk about that forever. So I'll go to the next slide. So here we are. So this population that is high burden of disease, not getting any better. And then you have these magical drugs. I think in 2017, 2018, we're seeing GLP-1s kind of be talked about, and then by the 2020s, they're coming on the market. And really, the returns are very promising. You're seeing Mounjaro, Ozempic, Wegovy, Zepbound, a lot of these drugs coming on the market that are basically causing people to lose weight. Leading to a lot of folks to actually lose weight and keep the weight off, which is great, right? It is a great. Of course, it's still subjected to the lens of stigma, right? Well, people are just trying to lose weight without doing the exercise. They're not putting the effort in. Whatever the case is, if it's a disease, it needs treatment. And if this is a treatment, let us try to get access to that treatment, right? So then by 2022, there's this shortage. There's a shortage of it. And then there's this idea of well, we'll have to microdose it, right? We'll have to cut it up because there's a shortage. We can't give you the 10 milligrams of Mounjaro or Ozempic. We're going to give you 5, or we'll titrate it a certain way. So we'll try to make it work. And then there's this kind of, so compounding has always been there. Compounding, so the difference between counterfeit and compound, counterfeit is absolutely bootleg, false, not true. And then there's counterfeit that is, that there's counterfeit that basically, or that's counterfeit. Then there's compounding, which is basically like, think of somebody who's allergic to certain medication or the coding of a certain medication that has to have it a certain way, or it has to be microdosed in a certain way. And so they go to a compound pharmacist that'll basically say, say, okay, your kid is throwing up this pill. Let me put a sugar coating over it so your kid can take the pill. That's a form of compounding. It's personalized. It's broken down, and a compound pharmacist is trained to do that. But in this case here, the compound pharmacies are based in maybe New Mexico. Maybe they're based in China and have an operation through New Mexico, and they're selling all across the country. They don't see those patients. And if they see them, they maybe see them on a Zoom session for 5 minutes, and then they write their prescription, and then that's how they get it. There's no like blood work. There's no, an actual, for example, for Mounjaro and Ozempic, there's a retinal exam. There's none of that detailed stuff. It's just really, I write, rubber stamp a prescription, and there you go. And so the drugs start flooding the market. So you have these compound drugs that start flooding the market, and you saw the Super Bowl ads, right? You saw Serena Williams, and so then you unleash the compounding. Next slide. I won't go through all the details of it, but just the genesis of compounding. Compounding, we've heard this story before. And in 2012, if you remember the New England Compounding Center with meningitis, 100 people died from contaminated vials of meningitis. Over 750 people got sick from it. When they went in, they found the vials in this kind of backroom factory that had fungus in it. I mean, you could visibly, the reporters would say, you could literally see on the vials that there's fungus in the vials. And these were the vials of meningitis vaccine. So after this happened, it was considered a huge tragedy and a huge breakdown in public trust. So Congress stepped in and they said, okay, we're going to do a 5% cap. You can't, if you produce compounded stuff, you can't export more than 5% across state lines. Great idea. It just never was enforced. API, active pharmaceutical ingredients, largely came from China and India. They would come in, they're produced in China and India, they're brought in through a place in Denver, and they're sold in other places. And when you see the package, it says it's coming from Denver, but it's not made in Denver. It's made in China and India. Again, repeat warning letters coming through, but nothing really. There was a pivot idea that maybe the states could do the work. Maybe the states, and I was give you the example of Illinois, where they had 37 different compound pharmacies based in the state of Illinois, and they had about 2 or 3 locations per pharmacy. So in total, about 90 different sites, pharmacies throughout the state of Illinois, at one inspector for the whole state of Illinois. And his job was to inspect all 90 of them. And I'm thinking to myself, like, it would be the equivalent of having somebody who say, your job is to text these people and ask, are you good? And that would be the extent that they could possibly do that. That literally was one person for 90 different pharmacies in one state. Can you imagine that in other states? So again, the rise. So the shortage kind of gave this impetus to say, well, if there's a shortage of it, we can fill in the market with compounded versions. And if it's expensive for folks, we can break down the price and give them compounded. And in some cases, we can actually give them counterfeit. And so, hence the beginning of the counterfeit markets here. So next slide. So then there's a counterfeit market here, right? And so my sister lives in El Paso. She's an OBGYN. And I was talking to her about this issue. She's like, Ray, you don't even understand. Go to Juarez. Go on the other side of the border, and you'll see it like loud and clear. Literally, people, they have places. So here's a photo of farmacias similares. Lo mismo, pero más barato. Like similar pharmacies. The same, but cheaper. They're all over the border. They're all over, and they're producing drugs or not producing drugs. They're basically selling counterfeit drugs that are entering the U.S. market. And so folks are using this. This is not to go to the beach. This is not to get into an evening gown. This is simply mere survival. About 50% of folks who are obese don't want to get diabetes. They don't want to get they don't want to become the $1 million patient. They don't want to have all these diseases. So again, in efforts to try to seek some release is to go into these spaces to try to get this. But again, unfortunately, they're not getting it. So go to the next slide. This is what shocked me. So the National Poison Center had, we were hearing about this and we were seeing this more and more, but the National Poison Center was documenting actual cases that were reported to the FDA or to the National Poison Center. About 17 deaths attributed to compounded and counterfeit GLP-1s. Almost 23,000 cases, an increase of almost 1,500% of that were related to this from 2019 to 2025. About half of those cases were Black and Latino. Again, folks who are so desperate that were seeking these medications, getting the wrong medications, and finding themselves either dead or severely injured by it. In some crazy cases, you see formaldehyde being put into them, unknown chemical substances, ingredients enough for human use. We've heard this story before. Again, the National New England Compounding Center in 2012, they had the same problems. So let's go to the next slide. So what does it look like? So I just wanted to give you some examples of some of the ads that you see. And I'm sure my phone is right in front of me, so I'm sure if I go on my social media, I too will see these ads just based on this conversation. So PSAs for girls, you don't need to be obese to start a GLP-1, and then it goes into different treatments. Again, you can click on the ad, find out where you can order it from, and then you go on to the next place. So go to the next slide. And then you see the deceptive marketing. Doctor trusted. What does that mean? FDA approved? No. Doctor trusted, huh? So it gives the illusion that you're getting something that is approved by physicians, but it's not. You get the Mounjaro, $191 a month, which is much cheaper than what you would pay out of pocket, which would be $1,300 a month, or over between $1,100 and $1,300 a month for actual ones. So then you're seeing, all these ideas: microdosing, tested, trusted, as if it's a physician is actually looking at this. Next slide. Again, what we're seeing here is that you see folks that are basically bypassing FDA rules. They're using foreign markets, bypassing the rules, setting up a shop in somewhere in the US that are selling this stuff. And you're seeing the volume. They're making a lot of money, tons of money. And the new way of doing, so that's the online guys. And then there's this new kind of breed, which is the med spas. The med spas are sprouting up everywhere. You're seeing them in places where they'll have somebody opens a med spa under supposedly a doctor's license. That doctor might own 15 of them, 20, 30 of them. He doesn't live there. He's not based there. They have somebody who's there literally giving these very strong medications to folks with no physician in sight, no nurse in sight. So again, we're seeing that happening. And then there's the actual street vendors, the bootleg ones, farmacias similares, where you see people just literally on the street selling you this stuff. No oversight, high risk, low regulation. And again, Latino communities being hit the hardest. Next slide. So med spas, we can go a little bit into that. So you see med spas, this has become a bigger thing in certain spots, particularly Miami, South Florida. You're seeing a lot of this pop up, but you're also seeing it in a lot of other Latino communities where folks are basically having, it started out with the idea of this alternative medicine, having certain types of therapies, like kind of homeopathic therapies that are more kind of aligned, that are less kind of traditional Western medicine based. And in some ways, you're seeing it grow. The population is growing, the people who are using it more, and increasingly, if you go to the next slide, increasingly more Latinas are going to it. Again, more Latinos and Latino males are more African American women than African American men are being affected by obesity. So again, it just seems only natural that like you would see them turn to med spas and turn to. So about a quarter of all spa visits are Latinos, and again, of most of the spa clients, 85% are women. So what we're seeing is these ads here, and I wanted to show you this one here, Farmacia Similar or Farmacia Pharmacy, and they offer free delivery. They say English spoken. They offer painkillers, Viagra, diet pills, Cialis, amoxicillin, penicillin. This is a place that is right on the border, in the U.S.-Mexico border. Again, and it shows a little guy in a moped literally delivering drugs to you. I mean, imagine that, like a drug so powerful, that I mean, a regulated drug that is being delivered from a guy in a moped based on a phone call that you can call here. So again, go next slide. So we're seeing this problem go on and on. Counterfeit and foreign ingredients, active pharmaceutical ingredients and compounded drugs are coming from registered Chinese suppliers. Like it's India and China, but predominantly China. Labeled for research only or for veterinary use, but somehow they're not being used for veterinary use, they're being used for human consumption. 25% of these facilities have never been inspected, and about 80% of the unregistered API shipments go into the US unregulated. And of course, no surprise that we started seeing at even reports that feds knew for years, this is from the LA Times, feds knew for years that fentanyl tainted pills from Mexican pharmacies were killing Americans. That folks were going to the Mexican side, getting these drugs that had fentanyl in them, and they died from it, and yet nothing was being done about it. Again, the regulatory mechanisms completely lost. So you can make this argument for any group, but what I really wanted to show is why. So I think of this problem, I think of it as a trifecta perfect storm. On one side, you have a high disease burden. The other side, you have limited coverage because Medicare doesn't cover it, which is kind of the gold standard that sends the ripple effect to all private insurance. A lot of Medicaid, a lot of the states that covered it through their Medicaid programs are no longer covering it. California is rolling it back. Pennsylvania is rolling it back. So you're seeing a lot of the coverage being lost there. And so folks are desperate for it. So they need to go, they find some relief. So they go this way. The last part of it, if you go to the next slide, is what I think makes the third part of the trifecta, which is I think why Latinos are uniquely situated in this case. If you go to the next slide here, oh, there's a typo. I'm just making up words here. One of the things to think about when you think about Latinos and how we absorb information and where we get our sources of information, it's important to look at things. Number one, social media has displaced television as a big source of information for Latinos. Another aspect of it, so YouTube, WhatsApp, Facebook, again, you see this so Latinos are turning to them for news. Another way of how Latinos absorb that information is that when Latinos get information from it, most of the folks, they get information, they say, I don't buy that, or I do buy it. If they don't buy it, they say, okay, fine. If they do buy it, okay, fine. Like I believe it, and I'm not really spreading the word to anybody else. For Latinos, particularly Latino men, I would say we're the most explosive, we're the most gossipy, is that we tell other folks. So you see something on YouTube, and we take it as truth, and we're out spreading the ripple effect. We're like as if it's gospel here. We have to go spread the gospel truths of like, well, this is what I saw on YouTube. And we all have an uncle or an aunt like this. Yo miré esto en YouTube. I saw this on the YouTube, and they're spreading that over and over again. But the problem is that when you look at Facebook, and we know this from the Meta leaks, that of the misinformation budget, 87% was only targeted to English. And we know this from COVID when we say COVID vaccine causes cancer, 85% of the time that was flagged as misinformation. But if I say la vacuna de COVID te puede dar cáncer, which is exactly the same thing in Spanish, 85% of the times they went through. So hence when we see GLP-1s being marketed as doctor trusted and reliable and safe and so forth, it is only natural that you see this coming directly through a Latino audience with no barriers. You're seeing influencers coming out saying, I lost 75 pounds on Ozempic, but you're not selling Ozempic. You're selling Ozempic patches, which do not exist. Ozempic was meant to be an injectable. And so now you're seeing folks literally making money off selling these bootleg patches, vitamins, whatever they're trying to sell, that are supposedly going to offer relief to people, but they're not. They're just making a lot of money off of that. So next slide. So again, what we're seeing when deception sells, people believe this stuff. They say it so frequently that people actually believe that the fictitious ads are actually credible. And with the National Consumers League, we did they did a survey, and then we did a petition to the Federal Trade Commission, to the FTC, and talking about this exact issue and why we're seeing so many folks who are being deceived by these ads and buying into it, and particularly for Latinos, where there is no filter, and it's becoming a bigger problem. So next slide. Again, we see the dosages, the harmful effects, and then we're seeing the actual outcomes. About half the people who are getting this are Latino, Black and Latino. So next slide. So our call to action is, okay, we have this 5% rule that we put into the New England Compounding Center. Let's do something about it. No more interstate loopholes. If we can't do this. The personalization schemes, we're going to add additives, B12 shots, B12, whatever it is. Okay, if it's real, it's real, but let's have it individualized. Don't actually have it marketed to be this personalization of GLP-1 when it's really not. We have League of the United Latin American Citizens. We get that Latin American citizen somehow invites so many folks to try to reach out to us. That they have a telehealth place based in Brazil, but they're trying to sell it to us here. And I'm like, how does that work? Well, we have a doctor in Brazil that meets with you online, and then he tells a doctor in Florida to write a prescription for you, and then you get the prescription. What? That makes no sense at all, but exactly the case. We see this be happening more and more. Obviously, APIs, supposedly research only for veterinary use, it's being used on humans. We need to crack down on that. And again, investigate Metaspots, look at telehealth centers, sellers, storefront vendors. Make sure that I give you stories upon stories about how this is a bigger problem for Latino communities. We are really sponges for misinformation, and also like really big targets for the black market. And so, anyways, next slide. So we could basically talk to the council on this issue, but the idea is like we can also complain about there's not enough information and not enough attention. So in many ways, what we've done as an organization to try to like just amplify that market. We've gone into amplifying our digital voice, going into TikTok, Facebook, and really talking about it there. We're also advocating at the Capitol Hill and state legislatures. We have about 425 local councils. Some more active than others, but in many ways we still make a voice at the local level and at the federal level. The Treat and Reduce Obesity Act is the federal level, and for a lot of states, meeting with the local Medicaid commissions and talking to them about why GLP-1 should be covered in the state Medicaid program or state health employee health programs. And then we also do our little ferias de salud. I put the picture here on the lower left of the way LULAC does it. We have, free haircuts for the kids, back to school haircuts. And since we get the kids, we tell them bring your aunts and your uncles and grandma and everybody. And since we have them, let's get screening for diabetes, get screening for eye health, and so forth. And then we also push certain things. So we can talk about positive health messages that way. So that's another way we do. And then my last slide, I know Christina's asking me to shut up here. I will end with this. I've always talked about my mom, and I talk about my family a lot in my presentations, and I talk and I usually give my mom's story as like kind of the reason why I talk about this issue so often. But when I think of the issue of obesity, we often, as I mentioned earlier, we stigmatize those who have it, and we forget, like, when I think of my mom, she was the hardest working person I know. She worked 2 jobs. She worked in the fields half the day and then for 8 hours, came back home, showered, and then went to the potato factory. I grew up in Idaho. 16 hours every single day as a single parent. She was the hardest working person I knew. But by the age of like her late 50s, her weight had gotten so far out of control. And she had reached a maximum weight of about 525 pounds or 535 pounds. And with that came everything, the cocktail of drugs every single morning. You had sleep apnea, you had the congestive heart failure, you had everything, hypertension, diabetes, you name it. Every single morning with about 20 medications she had to take. And she did lose a lot of weight before, like, she kind of went along. But again, it was a whole lifetime, basically from her throughout her 60s, of just getting sicker and sicker. By the time that she passed away at the age of 73. It got me thinking a lot about everything. And it got me thinking a lot about my mom's friends who also passed away. My mom outlisted most of her friends who also died early 60s, mostly all Latina, all obese, and died in their late 50s, early 60s. And one of the things I thought about was my mother's mother and my mother's grandmother on the maternal side, and how great, we always talked about how great genes we had. My mother's grandmother lived up to 102, and my mother's mother lived up to 109. Mom lived to 73, and I think about that, it just made no sense to me. How is it that grandma and great grandma, who were born in a rancho in a village in Mexico with no running water and no electricity, could live into triple digits, and mom, who was born in Westlake, Texas, largely grew up in the US, dies 35 years less? Again, it doesn't have to be this way, but a lot of times it's the built policy environment that we've enabled and we've allowed that has made it this way. And so again, it's just more impetus for each one of us to fight harder, to be smarter, to be more vigilant about these drugs that are coming into the market, and to fight to improve access for our community. So, thank you.
All right, thank you, Dr. Serrano, for that wonderful presentation. I just want to echo how much misinformation there is online in Spanish. I'm glad you highlighted that. It's a huge problem. But that also, gives me a chance to mention, with Latinos First Secure Retirement, we are launching Seguro Social Adelante. So it's social media sites to provide Spanish language information. So it's not going to be sufficient by itself. There's so much misinformation there, but we are engaging and trying to get the right information out. We've just started putting out content. As I mentioned, we're doing the rollout on November 19th, and then we'll be promoting it a lot more. So that's something to look out. But Dr. Serrano, one thing I wanted to ask you about, you mentioned these SNAP cuts coming up in 1 week's time. And unfortunately, it doesn't look like there's much negotiation or compromise going on in the Hill. So could you just talk a little bit more about kind of the impact of the SNAP cuts and like what we should be doing over the next week or so to kind of prevent these catastrophic cuts?
Yeah, I mean, it's a tough situation. And even I equated to like the aftermath of HR1 being passed. And I remember talking to Dr. Cruz about this, and I was like, she's like, what do we do? I said, well, many ways we can have papeleo clinics, we can have paperwork clinics, where we basically get a room in the library and tell folks, okay, if you need to renew your Medicaid, or if you need to renew, apply for health insurance, we'll get a bunch of volunteers and just help people fill out the forms that way, because it'll break down at least the stigma of saying, what do I do now? I don't know what to do. They weaponize red tape, and now I need to and so we could, as kind of advocates, could try to help with address that weaponization of red tape. With Medicaid, I think, with the SNAP benefits, I suspect a lot of folks who are going to be affected by it, and they're already be affected by it. We need to find out what food banks are available, what they have, and find ways to other organizations can step up. I know just around the corner here, I always ask those bakeries and the coffee shops here in DuPont Circle, what do you do with your leftover stuff? And they're like, we donate it. If they don't donate it, I don't go there anymore. I make it a point to like make it donated because the people are really hungry right now. They need to have some kind of sustenance. Again, $6 a day wasn't a lot of money, and the fact that they're toying with that and they're really starving, it reminded me of. Sorry, it really bothers me, but like it reminded me of the story of the Montgomery bus boycott in Alabama. Everyone knows the story about Rosa Parks, and they know that story and the bus boycott that lasted over a year. What they don't know is that 85% of the population that used those buses were African American. What they also don't know is that as a way for the white population to get back at that population for boycotting, is that they shut down the food banks. They literally wanted to starve people to end the boycott. And to use food as a weapon to basically get people to come back to the negotiating table is such a very cruel thing to do, but it's not unheard of. We've seen this before. We saw it in the 1950s. We're seeing it now. But I think one of the ways we can step up as us as advocates is to provide those resources, just call food banks and say, hey, what's available? And so when people call us, we already have that answer available to them.
Thank you. Mr. Johnson, I tend to focus on policy and legislation, but we have a lot of care providers and community organization leaders here and local clinics, and so what could community-based organizations and local clinics do to kind of better leverage 340B savings to kind of improve care and chronic disease management in our community? What could they do with the current program? And then the second part is, how could they advocate to make the program better for our community?
Well, I would encourage any patient, first and foremost, to make sure they ask if either the hospital or the clinic that they are going to is a 340B hospital or clinic. And I think, whenever they see an intake person in a hospital, or a triage person, at a clinic, that's an easy question to ask, and that facility should know. And I think covered entities should be aware that patients want to know if they're a 340B program and if they're getting a discount from the program, and ultimately whether patients are benefiting from that covered entity getting a discount. So there just needs to be more awareness, not only from patients, but also covered entities should know that patients are aware. The other thing is that, contact your representatives. We're trying to get a solution at a national level. I think your representative, both in the House of Representatives and also in the Senate, need to know that people care about this issue. And I would say it's probably more than likely at this point that if the Senate comes up with a comprehensive solution through the Health Committee, I think that's probably going to be the direction that the Congress goes towards. There's legislation that our coalition supported in the past that's being considered in the House, but I think we know the House tends to be a little more less bipartisan in this environment. But we've supported those principles. I think it's important to see what comes out of this working group and eventually what comes out of the Health Committee. But be vocal and be active and be aware.
Absolutely. That's great advice. And if I could just expand on that, because I live in Washington, D.C. It is a great city, but a lot of people outside D.C. think you have to come to Washington to lobby. And actually, it is the opposite. They hear in D.C., they hear from tons of people. There's tons of lobbyists. And what's really more effective is when they hear from you in their community at a local town hall, looking at the person in the eye, going to the district office. So do not think you have to go to Washington, D.C. to lobby and have your voice heard. It's the opposite. We're looking for people outside of D.C., because they get it so much here. So you're more effective outside of D.C. That's why we love groups like LULAC. They're so strong in communities across the country. So please do not think you have to go to DC to be an effective advocate. So I just want to
Sure.
add to what you said. Dr. Serrano, let me go back to you. I like in your presentation how you talked about, here's federal policies and here's state level policies. Like we know in this current Congress, it's hard to pass national legislation, but I've seen states like California and New York and other states kind of pass a lot of good stuff at the state level. So, how would you balance your advocacy on these issues? Because there's only 24 hours in the day. Like, do you think people are better focused on federal, on state? Does it depend on the state? Can you talk a little bit about those dynamics between the state and federal level?
Yeah, I think, it's a little bit of like venue shopping. So we have there's so you can go one way, right? You can go the idea of the snowball effect, right? We're going to start the small little snowball in one state and add to it, and then eventually that would be a huge ball of snow. It's going to like tumble down the doors here, and so you create a collective mass by getting different states and pushing that forward to become federal action. That is one approach, and I think it has been wise to do that. We had, states like Mississippi, and you had states like California, which really would never be in the same category for anything, but we're actually having their Medicaid programs cover GLP-1s, which is great, partly because they both recognize it was a serious issue. But at the same time, at the federal level, there's still an effort that the Treat and Reduce Obesity Act that has been brought up. I think I want to say since 2012. Maybe later, but it's been brought up several times. It's never really made it out of committee. Last year it did. Last year it made it out of the Energy and Commerce Committee. After a lot of us going to the Hill, educating folks to say, here's an issue that we're like, we could hear about CBO estimates here and there, but like, let's talk about the cost of inaction. If you don't, there's a economic cost to inaction because you're not treating this disease early on, and it's leading to a lot of other, other diseases that are going to be more costly. There's a human cost to inaction. As I always tell the story about my mother, like the fact that I would have loved to have her be 35 years more on this earth. I would have loved to have her watch this presentation, but I don't have her here. And a part of it is because these drugs weren't around then, and if they were around, I wonder whether we would have access for it. So again, there's a human cost to it, but I think as we got to that part, then the Biden administration I was actually, I'll never forget, it was the day before Thanksgiving that he did his proposed rule to include GLP-1s in Medicare and Medicaid. And then that didn't get rescinded with the change of administration. And it wasn't, we kind of were hoping and kind of trying to push for this to be sustained. But on April 4th, the new administration basically said, no, we're not doing this. And then there was all this misinformation about like how expensive it would be. And the reality was it would not be that expensive. And it's already expensive because you're not treating it, except that it's not being borne onto Medicare, it's being borne onto the actual folks who are being affected by it. So again, I think there's a little bit of venue shopping, but I think we can walk and chew gum at the same time. You can basically address, so one of the things we do, because we have our local councils or state chapters, we get them to step up there, but we also do at the federal level continue the education. Me and Dr. Cruz and a whole span of folks have gone to Capitol Hill walking, really getting our steps in there. So it's been a lot of fun.
Great. Well, thank you so much. I'm going to give it an applause again on behalf of all the audience that you can't see. I want to applaud you. Before ending today's event, I would like to welcome Miss Lorena Curi. Did I say that right? All right. The Global PRBG Lead for the Organization of Latino Achievement at Bristol Myers Squibb to share some closing remarks. Welcome, Lorena.
Thank you so much, Jeff. And yes, you said Lorena Curi right, and I appreciate that. Wow, I had my closing remarks prepared, but I think that after listening to everything that both Dr. Johnson and Dr. Serrano shared, it is concerning, right? The need to react that we have right now. And I do believe that both presentations were an important call to action to address some of the most important points highlighted in the report presented by NHCOA. When Dr. Cruz mentioned about the cholesterol screening and kind of personal recommendations, it was resonating with my head, like, yes, we need to do that. When Dr. Johnson presented everything related to the 340Bs and the need for civic literacy that our Hispanic community has, and understanding the drivers and barriers on their own care is also important. Osteoporosis and how, like, this is not something that would happen to me. I am in no risk. Back to the story of Dr. Serrano's mother and grandmother. Thank you for sharing yet. And now with the GLPs, all of this has a huge impact in how we live and how we act and what we need to do. And of course, the important impact that all of this has on mental health. So I just wanted to say thank you and how valuable all of this is. As you said, my name is Lorena Curi, and I am one of the persons that leads inclusion and community impact efforts at Bristol Myers Squibb, where our commitment to health equity is not only a priority, but shapes the way we work and who we are working for. And we know from research that health disparities are rooted in so many barriers: socioeconomic, linguistic, cultural. And the SHOAR report from 2024 presented and highlighted already many of these, right? And how this implies like different therapeutic areas, especially some of those that we care for at this point as a company. We also have, as a company, specific research on the lived experience of our patients, showing how Hispanic adults are deferring care because of affordability, right? Or just simply because this is out of network, or this is a different provider. But we also understand by our role and by our information the relevance that the concordance factor or level of care or level of trust, sorry, that a patient may have with a physician that mirrors them, or that understands them, or that looks like them, or that speaks like them. So we do have a significant gap to cover, considering that a very small part of healthcare providers would identify themselves as Latinos, right? It's not only about the language, and when Dr. Serrano was sharing all this information about ads in Espanol, that the community really, really trusts, we do see a very important disconnection. And looking into heart disease, again, related to the cholesterol screening and to the obesity as well as part of the care continuum. Well, heart health, heart disease is the second leading cause for death among U.S. Hispanics. So risk factors like blood pressure, cholesterol, and diabetes are not only underdiagnosed and undertreated, but according to what we just saw, also impacted by a lot of misinformation, not only social determinants of health. And similarly, when we look into mental health, which is often overlooked and critical, although we as a community may have similar responses than other groups, we do bear greater barriers to care, to high quality care. And we still have some co-occurring conditions that may be harder for us. Plus, of course, like the stigma and secrecy that we face. That is one, well, these are some of the many reasons why community engagement and community outreach are key to build awareness, education, and healthier communities in a future that could definitely benefit from drug discovery and innovation. So from a collaborative standpoint, as an organization, we have done multiple activities to bring the right education to the right populations through the right messages and through the right messengers. I won't go into detail into deep detail right now because I know we're almost on time, but I would just appreciate opening an invitation to you all to empower our communities by strengthening outreach and accurate education and increase representation in healthcare and research, and more importantly, to invest in health equity programs and policies that we can continue to help the patients and the caregivers we serve. Together, we can create a future where Hispanic and Latino families have access to high quality, culturally competent care, and we can definitely create a future where this is accessible for all. So let's continue to advocate, to educate, and to collaborate, because our communities deserve nothing less. I will just wrap up with one of my favorite quotes from Dr. Malcolm X, saying, "If you change I for we, even illness becomes wellness." And on that note, I wanted to thank you all, and thank you, Jeff, for leading this very important session. Thank you, Dr. Cruz. Thank you to all the panelists, and thank you to all of you who are listening to this very important information. Muchísimas gracias, and I'll hand it back to you.
Thank you. Thank you. What a way to close. What a way to close. Just kind of a few odds and ends. I want to just thank everyone again, all the speakers, all the audience for joining us, the sponsor partners, and all you guys for participating in this briefing. Again, we are going to have the Latinos for Secure Retirement Coalition and Seguro Social Adelante campaign rollout on November 19th. So you could, go to Latinos for Secure Retirement social media and find out information. And then December 10th, National Hispanic Council on Aging is going to be back on Capitol Hill with the briefing. So I hope to see some of you guys there who are in the area in person then, but look for information about that online as well as their annual report. And again, if you want to, you could join National Hispanic Council on Aging's individual membership program for just $25 a month. So please go online and check it out. And thank you guys again for joining us. We have a lot of challenges, but like I said, I've worked on the Hill for 15 years. You don't always win right away, but when you work hard, you work smart, and you build coalitions and bring more people, I've seen some really substantial victories in Congress that really made a big difference to improving a lot of people's lives. So please keep hope, keep up the fight. I hope to see you guys online November 19th and in person December 10th. Thank you guys very much.